Welcome to this BTOG podcast. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London, and I'm the chair of the BTOG steering committee.
And I'm Emma O'Dowd. I'm a respiratory physician from Nottingham, and I'm a steering committee member alongside Tom. And this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancers.
Now, it's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything we discuss today. Hello, everyone. Welcome again to another BTOG podcast, continuing on our theme of locally advanced disease and all ways of treating it. We're delighted, Emma and myself, to be joined by my colleague and friend, Jason Adhikaree. He is a medical oncologist. He's an associate professor at University of Nottingham and works clinically up in Nottingham as well. So, Jason, welcome to this BTOG podcast. Thank you for joining us.
Thank you for having me.
So to remind people, this is the third in our series. We kicked off initially with Helen Liddicoat and we talked about staging and diagnosis in this locally advanced setting. We then talked after that to Safina Begum about surgery. And now we're moving on to the most interesting bit, which is the medical oncology bit, because that's obviously where it really gets great. And I can talk about clinical trials and it gets me very excited. So we're going to focus on the medical oncology, immunotherapy, chemotherapy bits. And then our next recording is going to be focusing on the radiotherapy aspects. So without further ado, I think we'll move on to probably non-resectable disease, Emma.
Yep, thanks, Tom, and thanks, Jason. Yeah, so we're going to start by talking about immunotherapy, particularly in non-resectable disease. So just to make it clear, these are patients who cannot have surgery because their disease is not operable or resectable. So I think, Jason, it might be helpful if we just start briefly, if you could, just with a sort of overview of what the data are in terms of the role of immunotherapy and what our most up-to-date data show for these patients with non-resectable disease.
Yeah, so for non-resectable disease, we're mainly looking at chemoradiotherapy initially for the stage 3 unresectables, and they are then followed with consolidation to durvalumab. The mainstay trial, which has been practice changing, was the Pacific trial, which was originally reported in 2017, and up to date in the updated survival data from 5 years of collection in 2022 showed that there is significant benefit of durvalumab over just chemo radiotherapy alone. Actually, the data is quite astonishing in this group. So the 5-year data for durvalumab in the durvalumab arm was 42.9% were alive for 5 years. So you just have to picture that this is patients with bulky stage 3 disease, which cannot be resected. And that's compared to in the placebo arm of 33% at 5 years. So, and that's the overall survival data, but even a third of the patients were progression-free at 5 years. So really quite a remarkable benefit of adding durvalumab, and that was compared, I should say 33% compared to 19% in the placebo arm. There was a post hoc analysis where it suggested there was no benefit for the PD-L1 less than 1% group. Hence, in England and the rest of Europe, we are only offering this for people with PD-L1 positive disease. The main concern, I think, initially was about pneumonitis, because, of course, chemoradiotherapy can cause pneumonitis. So can the immunotherapy agents. But actually, the grade 3 pneumonitis rates aren't as high. They're about 3% in the active arm versus 2.6% in the radiotherapy only arm. But any grade pneumonitis is higher with the addition of immunotherapy. But nevertheless, it's certainly been practice changing. In terms of other updates in regards to the stage 3 non-resectable space, Pacific 2 looked at initiation of durvalumab at the outset of chemo-RT, but there was no improved survival over chemo-RT alone, and there was an increased rate of infection in the treatment arm. And the most current trials are looking at adding other agents. So we are also part in, the proverbial we in Nottingham also got the Pacific 8 trial open with adjuvant anti-TIGIT antibody alongside the PD-L1 antibody.
And we always talk about trials, Jason, but then it's often translating that kind of trial population into our real world population, isn't it? Obviously, these patients need to have not progressed after they've had concurrent chemoradiotherapy to have their development based on the original Pacific trial. What proportion of people do you think we managed to get through all of that to be able to be eligible, sort of if we're looking at a real world lung cancer population in the UK rather than our trial population, often slightly different?
Yeah, I think that's an excellent question. So I think there's been a slow transition or migration, if you like, in practice, because one of the Pacific trials was actually looking at comparing sequential, I think Pacific 6 as a single arm trial versus the concurrent use, because there was, I think what has evolved alongside the drugs has also been the allied health service help, such as specialist radiographers, dietitians, having your rehab pathway set up, and all these things actually also contribute to improve success. And I know Nottingham's local audit data has shown more than a doubling, I think, of the patients completing chemo RT annually now compared to sort of 5 years ago. And as I say, that's likely mainly down to a multidisciplinary team approach, which is also relevant as we move towards the peri-operative approach that we're going to be talking about later. I think also there were significant changes in terms of those being able to have weekly carbotaxel. So this opened the door to more people having concurrent chemo RT rather than those purely having the 3 weekly more toxic chemo backbone. So I think those factors together meant that certainly we're seeing such a much greater approach of patients being able to successfully get through chemo RT concurrently.
You mentioned just back then about the PD-L1, and you said that in this post hoc analysis, I think was requested by the EMA, that if you were PD-L1 negative, you didn't benefit, and if you're PD-L1 positive, you did, and that very much influenced the use of durvalumab in this setting, in certainly this side of the Atlantic, whereas the other side of the Atlantic, people are a little bit less concerned. What's your take on it? Was that an unfair post hoc analysis that has prevented patients getting durva who should, or actually was it a rational way of picking out patients who aren't benefiting, and we should focus our drugs on people who it does work, not patients who it doesn't?
Yeah, I think that's it's a really good question, because as we know from the trial data's coming along here as well, it's not always consistent, it seems, about that kind of interpretation of what the value of the PD-L1 biomarker is. There's certainly, I think it is important to enrich your population of definitely those who benefit. So I'm certainly, and I think from memory, the hazard ratio was just over 1 in this scenario, but of course it was exploratory, wasn't pre-specified, etc. So with all those caveats, so I think it was reasonable of the European Health Agency to take that viewpoint. And these do come with extra toxicities as well. So I think it is fair, particularly in relation to Pacific trial. I think where it becomes more difficult, I suppose, is where we go and look at then, well, you could argue, well, the same post hoc analysis of Checkmate 816, Keynote 671, maybe showing similar trends. Again, exploratory in some situations, or actually pre-specified in others. But and then it gets harder to define what that means. And I think we need some better biomarkers, of course. I mean, that's the get out clause, but I say this probably, if you like, from a because if you take the big picture of what immunotherapy in lung cancer is like, we know there's a benefit on less than 1% PD-L1 expression in our adeno population and our squamous population with stage 4 disease. That benefit is less than those with positive disease, but there is still a subgroup what benefit. And actually the PD-L1 negative populations in all these groups, regardless of stage, may be a bit more heterogeneous than what we appreciate, and there may be some with who certainly are benefiting, and those what probably aren't at all, and then we are exposing them. But in the face of not having a better biomarkers to select that heterogeneous PD-L1 negative group, then we're left with the health authorities making that judgment, I expect.
And we've spoken a little bit about things like Pacific-6. What do you think about concurrent immunotherapy with chemoradiotherapy? I know there's quite a lot of interest in whether or not this would act synergistically and potentially, I guess, increase your tumor antigen visibility and improve response. But that's obviously balanced with that concern about toxicity. What are we seeing at the moment with regards to that?
I think that was what we were sort of expecting potentially, and that was where Pacific-2 went, but it hadn't proven to be better than chemo-RT alone. So the initiation at the outset of your chemo-RT, so hence that hasn't changed practice. And then there was some data in the earlier stage of looking at SABR and immunotherapy after SABR, and there was earlier phase data suggesting that there could be a synergistic benefit there. But then there's other data such as TESO, I think ASCO this year, the SWOG trial looking at stage 1, but also a bit higher stage with SABR. And even in the induction concurrent consolidation phases, that addition of atezolizumab didn't seem to benefit above SABR alone. So, and it did come with higher toxicity. So that trial was stopped due to futility. So I think there, outside of the Pacific trial, then at the moment, we haven't proven another role for the synergistic behavior, I suppose, of radiotherapy at this point.
So I guess at the moment it's sort of durvalumab and our data from the series of Pacific trials that we're using really to guide our treatments. And just finally, what do you think about dual immunotherapy? Do you think that's something that is going to come on with both anti-PDL, PD-1 targets and also other immunotherapy agents?
Yeah, so I think again, when we realize how good PD-1 and PD-L1 antibodies were in oncology, then there was, every year there's over 1,000 combination trials. And in lung cancer specifically, we've had some real disappointments, such as the skyscraper. This is in stage 4 disease. With skyscraper 06 actually showed worse outcomes with the addition of anti-TIGIT, and anti-TIGIT antibody was looking like the most promising. There's been some of the relativity trials have shown small benefits of LAG-3, but not statistically or maybe clinically significant, I would say. So at the moment, there isn't, I can't see a checkpoint on the horizon. Maybe the most interesting things we've seen in the stage 4 setting has been the bispecific with the VEGF antibodies and PD-1s, and we await to see how they develop in later phase trials.
Thank you very much. And so I guess to summarize what we might say whilst we get thinking about the non-resectable bit is the standard of care is chemoradiotherapy followed by durvalumab, roughly 10% 5-year overall survival benefit, which is very significant. It really is. And it was the first time we saw a change. It is limited to PD-L1 positives in the UK and Europe, and that probably does reflect where the activity is. Bringing the immunotherapy forward, giving it the same time as a chemo rad doesn't appear to benefit. In fact, it may cause some trouble. And there's an ongoing question, although we can't do it in the UK, as to whether you can use durvalumab after sequential chemo rad. So that's the non-resectable. Now, what about resectable? This is where all the action's at, and every single meeting we go to, there's just this huge session, and everyone gets incredibly excited. Loads of trials with lots of numbers and lots of letters. It's an oncologist dream. We're going to try to make it understandable. So, Jason, the first one out the block was Checkmate 816. This came out 3-4 years ago. It was carbo, Taxol, and nivolumab given neoadjuvantly before surgery, but that was all that was done. There was no adjuvant setting. Can you just remind us what that showed? And then I might just quiz you a little bit about why it was so impactful. And before you do that, I'll just say to people, neoadjuvant chemo wasn't something we really did. If we go back to before the immunotherapy era, if something was resectable, you had surgery and then you had some adjuvant chemotherapy. We didn't really do neoadjuvant. So getting back to neoadjuvant thing was quite different. Jason, what was the headlines you took away from Checkmate 816?
Yeah, so I think, as you say, just the setting pre-2023 was really a 5% improvement with chemotherapy, mainly cisplatin chemotherapy based, which we all know is harder for a patient to take, and a 5% improvement in disease-free survival as well. So that was quite modest, and that was what I think most of us quote to patients based on the latest meta-analysis, and there was a number of trials done over 15 years ago looking in that space. So coming into the neoadjuvant space, the Checkmate 816 looked at, well, it had 3 arms, but the main arms we talk about is the nivolumab chemotherapy versus chemotherapy, and that was for 3 cycles. So this included the patients we would typically give our adjuvant treatment to, so more than 4 centimeters or node positive.
Yep.
And I think what was remarkable about this was that there was a complete response rate of approximately 24% in the intention to treat arm. In fact, if you actually look at the patient subgroup who went to surgery, it was about 30% past CR. So in a modified intention to treat analysis.
And
so
just to explain to people, when we say pathological complete response, what we mean is when the pathologist looks at it under the microscope, there is no viable tumor left.
Yeah,
which is extraordinary.
Yeah, and that was absolutely, completely out the park, really, compared to the chemotherapy alone. And actually, what our biggest worry at that time was that this would stop people getting to surgery, that surgery, if they got to surgery, surgery will be a disaster because they'll get sepsis, infections, they'll bleed more, they'll be anemic, they'll be in terrible shape. But actually, the data produced by BMS suggested that some of the surgical outcomes were better, shorter surgery time, better recovery, less pneumonectomies, etc. So now the surgeons also will also add that they do feel that sometimes the operations are harder post-neoadjuvant, and that's, for example, the lymph nodes being more solid, and if you've got bulky N2 disease. But I think there was certainly some reassurance from my perspective anyway, that wasn't happening. That consistent among all the trials, though, there are approximately 20% who don't get to surgery, and there's a discussion about that, which I'm sure we can elaborate on. And then that trial data showed that after 2 years, which is the first data that comes out, what we call the event-free survival. So this is taken from randomization from the point of you started your treatment, which is a bit different to disease-free survival for those in the adjuvant treatment, because you've already self-selected a group of patients there. But in the event-free survival, the 2-year rate of being relapse-free was basically 64%, which was compared to 45% with chemotherapy. So now, I think that's really key number, actually, because I think if you're a patient with a lung cancer, yes, 5-year overall survival, that number may not mean anything to you, but what you want to know is your principal aim is to be free of your cancer. And that's what you really think you're buying into when you go for this curative intent treatment. So I think the difference between a less than 50-50 chance of being free of cancer 2 years from when you've signed the piece of paper versus a 2 in 3 chance of being free of cancer is how I pretty much explain it to patients, really.
Yeah.
And I think that's quite impactful to them. So as things stand, the 5-year survival data you expect would be quite similar because these are our best drugs in lung cancer. This is not breast cancer, etc. So,
and that data has certainly been impactful in terms of what we do, because when Checkmate 816 came along and it was approved by NICE, which it has been, I think a lot of us moved over. There are some caveats to that, which is carbotaxol is not necessarily everyone's favorite combination. It causes alopecia, can cause neuropathy, can cause infusion reactions as well. And as you might imagine, where one trial goes, everything else follows. So the next studies I'm going to quiz you on are what are called the peri-operative studies. And just to explain to people, what that means is these studies are giving pre-surgical or neoadjuvant chemoimmuno, but they're following it with an adjuvant regimen, usually a year of immunotherapy alone. And there's 3 studies. There's Keynote 671, which is a pembrolizumab-based one. There's Checkmate 77T, which is the one which is basically like the study we just told you about, but this time it also has nivolumab adjuvantly. And you have the Aegean study, which is durvalumab based. So we've got these 3. Jason, one of them stood out because quite early on it showed overall survival benefit. You've told us about event-free survival benefit. Which was it that showed overall survival benefit? And do you think it's just because they got their numbers out quicker, or do you think there's a genuine difference if we're giving neoadjuvant and then adjuvant treatment to patients?
Yeah, so the first one to show the overall survival was Keynote 671, which is basically the pembrolizumab with chemotherapy backbone. That was about October last year. They published that. So I think that is more they got their numbers out and how they designed the trial, because that was their 3-year follow-up or 3-year survival data, and their data was relatively immature at that point, actually. So whereas the Checkmate 816 that we've heard about at ASCO was actually a planned analysis, and is their final analysis. So actually, I don't think there's a difference per se from that perspective. I think it was one analysis was done just earlier than another. Just to flag up in the Checkmate 816, you don't necessarily have to have carbopaclitaxel. There was flexibility in 816. So, and actually that's an interesting thing. When I first saw some of these trials coming out, so the Keynote 671 was a cisplatin only trial. Actually, we don't have to use cisplatin to use pembro on the CDF. So surprisingly, there's some flexibility there on the CDF, not matching the trial, but
quite unusual.
Yeah, and actually, there's probably an evolution with people. So Checkmate 816 being the first one to be recruiting, actually recruited approximately about 75% or so with cisplatin, the others with carboplatin. They were stipulated for 671 that it was pure cisplatin, and then the Aegean actually had the flip. So I think by this point, physicians were getting more comfortable using the carboplatin backbone, and actually it was more like 70% had carboplatin.
I think people were influenced. I think people also influenced the fact, if you look at the 816 subgroup, the carbo patients probably did a little bit better.
Absolutely, there's a bit more benefit there.
Yeah, which is kind of counterintuitive, because when I was a trainee, I was always told chemo rad cisplatin's better, but actually Checkmate 816 was saying not. And I think it's really interesting NHS England have given us permission to use carbo, because it makes it much easier. Our chemo units cannot handle cisplatin. It takes far too long. And I think if you look at the national data set, everyone is using, well, not everyone, but most people are using carboplatin. So you described really nicely that it's not so much 671 is unique in having OS data. It was maybe the first one to come out. before I'm going to ask you which is your favorite regimen, you mentioned pathological complete response, PCR. We've also got something called MPR, major pathological response, to which for listeners is less than 10% viable tumor is evident, but some is left over. But it's the PCR patients who do really well. What's your take on it? If you've got a patient who's had a pathological complete response, whether they've had whichever regimen, can you tell people what that means in terms of their prognosis generally?
Yes, I think that the prognosis is at this point looking excellent. So what was most impressive probably from the ASCO data from Checkmate 816 was that, and this is, remember, only patients who had the 3 cycles of chemoimmunotherapy, is that there was a 95% survival at 5 years from those who had path-CR, and even the chemo was 100% in that. So and actually no one died of a lung cancer related specific death in that.
It was amazing. It's absolutely amazing.
Yeah, and so I think that gives us reassurance potentially that we don't need to be doing anything else for these patients.
Would you have the confidence if you knew someone had a path-CR, would you, and you had access to the adjuvant portion, would you say that's your lot, you're done, or would you still want to give the adjuvant because you're worried about what might happen?
I think I'm not necessarily worried about what happens in regards to medically. I think you need to discuss it carefully with the patient so that you cover yourself medically legally. I think it's
good answer.
plays a role in this. So I think the things I would discuss with a patient at this point would be that only about 40% complete the whole regime in Keynote 671, for example, and it's pretty similar in Aegean. So that's, yes, disease progression, but also adverse events as well. So this is not actually, free of harm. I think the answer to the other question of what do we offer, I think it's nice to have that option there, particularly if in terms of, as I say, medically, legally, in some ways, you want to be able to have that conversation with the patient that do I want to offer him the adjuvant phase or not to offer him the adjuvant phase, and have that flexibility to it rather than potentially Checkmate 816. Do I think you need the adjuvant phase? I'm not sure is the current answer to that from the data, because as I say, the 816 data is as impressive as the Keynote 816, broadly speaking. Comparatively speaking, the event-free survival is absolutely identical at 2 years. The 3 year, they've all then picked different time points of when they're going to tell us about their data, but there doesn't seem to be a difference. There are certain, so all of the publications, the peri-operative publications, that is, describe that patients who had the adjuvant phase did better, but that's obviously both in the chemotherapy placebo arm as well as those who went on to have the adjuvant phase of the immunotherapy. So there's a self-selecting cohort of patients there as well. There was a presentation last year at World Lung by Patrick Ford where he compared a similar group of inclusion and exclusion criteria patients in the Checkmate 77T, which is the nivolumab perioperative trial, versus the 816. And they felt there was a benefit in certain cohorts of patients that they're to the adjuvant phase, although, even in their publication, in the 816 publication, they say, well,
and that presentation was slightly criticized for basically not having 2 similar patient cohorts. They're actually different patient groups.
Yeah. So I think it is certainly not known. And I mean, even if you then do have a non-path CR, what I can't work out in my head biologically what the advantage of giving further immunotherapy is as well.
I agree. Yeah, if you haven't managed to induce your pathological complete response, what's the point of giving the same drug adjuvantly? And to my mind, a more logical approach, and we're part of those studies, and I'm sure you guys are as well, is saying, well, if you've got a pathological complete response, great. If you haven't, let's see if we can boost your adjuvant treatment, add in another agent, maybe a TIGIT inhibitor, who knows? Yeah.
Yeah, correct. Yeah, so we've got the Interpath neoantigen vaccine trial, which is a MSD Moderna collaboration for those who haven't received a PAF-CR, to potentially have a vaccine made, personalized neoantigen vaccine made for them. I think the other interesting trials are the ADOPT trial from ETOP, where they're going to look at what we all really want to know, which is observation versus adjuvant durvalumab.
Yeah,
in all
that's
patient
really interesting.
groups, and that's
Yeah. Proper
PD-L1.
pragmatic trial, that one.
Yeah, absolutely. So that I think that's the kind of thing we need to do as a community.
And as a stupid respiratory physician, I can ask you both this question. How much of this is the immunotherapy versus the combination of the chemotherapy and immunotherapy? So how far away are we from sort of saying, oh, maybe we can just give immunotherapy, or do we always need the synergistic kind of boosting effect of the chemotherapy alongside the immunotherapy in that neoadjuvant phase at least?
Yeah, I think there was, I mean, I can't quote them off the top of my head, actually. You should have told me you were going to ask me this, Emma, that the immunotherapy has been done in the neoadjuvant, and there is actually a reasonable PAF-CR with that as well. I think the worry in terms of in general is that we know even in people with high expression from the stage 4 is that about 20% progress with single agent PD-1 inhibitors. So, I mean, they may have more resistant disease because they've got high bulk disease and things. I think what you don't want to do is lose patients to surgery, and I think you need to be maximizing that effect. So even with the high expressors, I wouldn't feel comfortable giving them PD-1 only, because 1 in 5 progress. We know from other stages of disease. Then when you get lower down your PD-L1 expression, there's definitely the advantage, I think, of adding in the chemotherapy. And that's from, at the moment, chemotherapy is our best booster of the immune response. And I think that's the role it plays, really, presenting more antigens. And again, that was another rationale of why you might take a neoadjuvant approach opposed to a post-op chemo and adjuvant approach.
Yeah.
Although that's another question to be answered scientifically.
I think it's a great question. I think you're absolutely right. I mean, I think there is a benefit of the chemo and the immuno. We should remind people that in these studies, people just on neoadjuvant chemo still got a pathological complete response. And those patients still did really well, as Jason mentioned. It's just not very many people got the PCR. Whereas with the chemo immuno, many more people got the PCR, and therefore many more people did better. Jason, theoretically, in your pharmacy, you have access to all these regimens pretty much. Do you have a preference? Do you think one is better than the other? What happens in Nottingham in your practice?
Yeah, so I think in my personal practice right now, I have to say I'm using pembrolizumab purely because we're part of a pembrolizumab trial mentioned before, and you're allowed to go in even the adjuvant phase as long as you've had a pembro platinum backbone in the induction phase. So it's from a pragmatic, get them into a trial perspective. I don't think there is any difference between any of the drugs. I think from a practical NHS perspective, I'd love if ADOPT is positive and we can just use, I'll certainly potentially go back to 816 unless there was a reason not to use it, because I think that data is very positive.
And I guess we just need to touch on why it's really important that we actually get people's full NGS back before we actually start them on treatment, because what do we do, for example, if someone has an EGFR or other sensitizing mutation? What's the best option for these patients at the moment?
Yeah, so the CDF options we have really is to give them either for EGFR mutations. The ADORA trial was overwhelmingly positive, and and disease-free survival, your risk of relapse is reduced by between 70 to 80% in this patient cohort, which is the higher your stage, the greater your benefit. But
and just remind us the ADAURA trial, what it actually looked
yeah,
at.
so the ADAURA trial was surgery up front, as was pretty much the standard of care when the trial was designed, and then the patients had the option of having adjuvant chemotherapy. About half the patients received that, and then they went on to have an EGFR inhibitor for 3 years. So that's not a small undertaking. The difficulty is actually being able to prep a patient for such an undertaking, because when the respiratory physician sees them, they don't know they've got an EGFR mutation. And particularly at that time, the ballpark would have been surgery plus minus chemotherapy, and then suddenly these patients have been signed up to a 3-year sort of treatment regime. But we're getting more used to keeping more open mind and maybe talking more as things keep changing with 1 year of adjuvant immunotherapy for the non-drivers now, that we're probably keeping discussions a bit more vague, but also selling a package that this is actually a whole package you need to buy into. The other group is the ALK group, and in that trial they didn't give adjuvant chemotherapy. So in that patient group, we give 2 years of alectinib post-surgery. Actually, on the CDF, it also says you can't have received neoadjuvant chemo or chemo IO. So some of the trials actually did include EGFR in outpatients and didn't per se show harm in that group. But I think what is a big issue is NGS turnaround times and getting patients onto either chemo IO neoadjuvantly or making a decision to go straight to surgery so that they can receive their targeted agent. I think, and this is where you're playing a bit of CDF, sort of jumping through the hoops, because again, they stipulate you need an R0 resection. So if you've got an R1 resection, technically you're not meant to be getting your adjuvant treatment. And there isn't that flexibility of giving adjuvant radiotherapy and then going on to your TKI by their rules, whereas surprisingly the peri-operative CDF gave them a lot more flexibility, and we're allowed to give adjuvant radiotherapy for R1 resections. We're even allowed to give chemo-rad for R2 resections, followed by durvalumab, irrespective of what your IO agent was in induction. So there's data coming out on neoadjuvant EGFR inhibitors and ALK inhibitors. So again, they're looking interesting in terms of potentially getting some disease control going into your operation. But I think survival data will tell us whether that's beneficial. I think the other things we're looking at, which we've had open on Nottingham, is whether you need more than 3 years of EGFR inhibitor. And the trial we had open was Target, which was looking at 5 years of adjuvant EGFR in a single arm phase 2. But again, the maximum duration of these adjuvant targeted agents is not completely known. And although there is a positive overall survival data, for example, with ADAURA, we don't know if we're still just sort of pushing the can down the road a bit, whether we could select patients a bit better with maybe molecular residual disease, etc.
And so I think we're very much talking about our peri-operative neoadjuvant then for those patients at the moment who don't have any sort of sensitizing or targetable mutation. In terms of the trial data was quite clear about what proportion of people didn't manage to get through to surgery. What are you seeing in the sort of real world setting? Is that fairly similar, do you think, or are we seeing more patients that we're not managing to get through to surgery?
I think, well, when we've audited our Nottingham experience, it's actually been less. So we've had probably about 5% or so patients who've not gone to surgery, or not gone to surgery in a timely manner. You may be aware that we did have one lady who had actually chemo IO with 816, which was our only option of a regime at that time, who unfortunately had a bad colitis, had 5 hospital admissions, needed infliximab. She then had a stroke, and she actually was discharged on TDS carers, but actually had a complete response on a CT scan, and then we monitored her for a whole year. A year later, she regained her performance status, had a resection, still had a complete response on day 328 on the pathway, because I participated in the harm review for that one. So that was one of our ladies. One person got upstaged, coincidentally had a CT scan, which was ordered a year ago as his routine surgical follow-up in our cohort, and turned out to, just before he had his peri-operative treatment, shown to have a pleural met that wasn't obvious on his baseline scan. And then there was one patient who probably just developed had occult bone disease at probably at baseline, but became apparent clinically pre-resection, and then actually he progressed even during the treatment, and then declined very quickly after. So I think he would never have done well having to, he shouldn't have had surgery anyway. He would have declared himself straight after surgery. And we definitely had a cohort of patients like that. And I think the feeling on the whole is that actually those patients that aren't getting because of disease progression are those ones who are actually sparing having surgery, who would never do well or present themselves pretty much straight after surgery with metastatic disease. So actually we're probably not doing harm in that scenario.
And I think it's also about how you set up your service as well, which I think Tom and I are perhaps going to touch on as well in a later podcast. But I think obviously the ideal is to have a sort of co-located service, isn't it, where you can see an oncologist and a surgeon in the same setting. But I think what do you feel? Just as a sort of final question from me, Jason, do you think that we need to have sort of locally advanced clinics almost, where we're looking at these patients who we're potentially going to be putting through neoadjuvant and peri-operative treatment, so that we can actually make an assessment of them and they can meet everyone on the same day?
I think ideally, yes. And I say that because I suppose going back to the point we opened the podcast with, which is the chemo RT space, where I think most institutions would have seen an increase year on year of the people getting through successful chemo RT. And as I said, I think a large proportion of that is that multidisciplinary team approach that a lot of departments are set up now. So I think still, again, when I reflect on Nottingham's experience when we've audited it at the end of last year, we're not giving as many patients as are expecting neoadjuvant treatment. That might be good selection. It might be a bit of hesitancy as when we first started with the first licensing, etc. But I think if we had that multidisciplinary clinic as a one-stop clinic, then we would certainly help select the patients well. But again, like I said, the testimony maybe is that the few patients I feel we have actually deprived an operation from, who should have got an operation, because maybe we are selecting the patients a bit more carefully than maybe even the clinical trials did, because actually the clinical trials did actually have quite a high burden of disease. There's a high portion of N2 disease. For example, the durvalumab trial called Aegean was about half of the patients had N2 disease. It was about 45%, I think, in 816. Sorry, in 671 and 816. It doesn't tell you how many had N2, but it was on the old staging for that trial. But the 3A disease was about 63, 64% by the old staging. So that would have had a significant number of probably N2 disease. So these were actually not early stage disease patients. These were actually, there's quite a heavy burden of early stage disease. So, and I wonder how much of you know, all of us who do clinical trials know that there is a wait time of getting validation of PD-L1 on your baseline tissue, etc., and how much of that played a role in those patients just waiting a bit longer and having a bit bulkier disease. And outside, I mean, I was wondering along those lines as well. But I think when you do look at this approach, I suppose some of the other factors we can think about when we're trying to pick what is the best approach for a patient perioperatively, I think we also need to just think about the things we always did, which was heart function in these lung cancer patients. You know, have they had angina, MI recently in the last year or so? Have they got good renal function? And if they've got a bit of poor renal function, actually that's maybe getting your carboplatin in early is not a bad thing if it's stable renal impairment. You know, Keynote 671 and that overall survival, when I say, was it done too early? Well, their 3-year survival data, when they were made to do the hazard ratios, there was no benefit in the non-white population, in the East Asian population, less than 1% population, never smokers, and even in the over 65s. So that data was quite immature at that point, but it didn't show that. So the event-free survival was more reassuring that, you know, every subgroup pretty much benefited. But, you know, some of that is pause for thought. Certainly, you know, as extrapolating from other settings like the never smokers is a worry for some of us, particularly the stage 4 setting. We certainly see less good responses.
So that's going to bring me onto my last point, and this is going to be our last one because we are out of time, unfortunately. Kill me in 30 seconds, if you can, because it's a difficult subject. You're just touching on there who's going to benefit from treatment. There are some studies going on, and in some countries in the world with very large pockets, people are already looking at molecular profile, looking for molecular residual disease after surgery, maybe looking at molecular profiles before surgery. Can you summarize to people what that shows, and do you think this has a role in us deciding who should get surgery and who should get adjuvant treatment and who shouldn't?
Yeah, so I think there's all the studies have got some comparator biomarkers looking at circulating tumor DNA. And for example, probably Empower 10 was the first one to look at it, where when I talk about circulating tumor DNA, we're not talking about the NGS we do per se on our patients in terms of looking for EGFR, ALK, etc. They're looking at whole exome sequencing there and trying to get matched circulating tumor DNA compared to the actual tumor. And they're predictive of patients who will do worse. For example, what was interesting in Empower 10 was that disease, if you did not clear your ctDNA by the end of all that adjuvant treatment, even with atezo, your disease-free survival was only 4 months in both arms.
Are we seeing similar data in this perioperative space?
Certainly in the perioperative space, it's the same. So the 816 in their latest publication has shown that the ctDNA clearance correlates with pathological response. It's not perfect though, so there was about a 56% in the Nivo chemo arm, and that translated to about a 46% chance of a path CR. So it wasn't certain, so it's not completely predictive. But if you had no ctDNA clearance, no one got a path CR in the Nivo chemo arm, and 2 in the chemo arm did. So pretty much, if you haven't got your ctDNA cleared, you're not going to have a path CR. So it could be an early predictor of that. There was some interesting trials looking at, called Mermaid trials, trying to look at whether you could use minimum residual disease without imaging positive disease to try and extrapolate whether you needed durvalumab, for example. But they prematurely terminated, so we're not going to potentially find the full answers to those, which is a shame. But there will be other academic trials, I'm sure, which will elaborate on that.
Thank you, Jason. You and Tom have kind of persuaded me that the medical oncology world at the moment is actually an exciting place to be for these patients with locally.
Wonderful place.
So yeah, so I think it's been a really comprehensive overview of both those with unresectable and resectable disease, and hopefully things are now a lot clearer in terms of what we have available and what we are currently offering people. And next time, as Tom mentioned, we're going to be talking about radiotherapy in this patient cohort. But hopefully this has been helpful, and thank you for joining us tonight.
Thank you, Jason.
No problems. Thank you very much for having me.
Thank you for listening. We hope you enjoyed this podcast. For more information on BTOG, including educational events and how to join, of course, you can visit www.btog.org. Just to remind you, we would love to hear your comments, thoughts, questions about things we discussed. And for the really interesting ones, we'll even discuss them in our next podcast. You can contact us on info@btog.org or on Twitter @btog.org. Thank you very much.